Hey everyone, hope you're having a great day. Let me know if you can hear and or see me. Hey Kate. And Cassette, nice to see you guys. Gals. And Nicole, hello, hello. Stalwart crew. Priya, how's it going? Haley, Gavin. I don't know what you guys did today. Oh boy, I better turn my phone on, don't vibrate. Oh. Hey Isabel. We'll start here in a few minutes. We'll finish up the exam material for your test, which is on Monday, I think. What's up, Jackson? Let's see, today is not in April yet, barely. I got Professor Gardner after me. All right. Light day tomorrow. That's good. Cool. Hey, Molly. Aaron. I'll say this during the lecture itself when more people have hopped on, but I plan on being in person tomorrow for our review. I think it's our last time meeting. So if you would like to join, you are more than welcome to. Have other professors been doing like sign-up sheets or something to make sure there's not too many people in the room? I'm not sure how that's been going, but another scientific article, I think. Oh, that'd be cool to check out, Brian. Oh, you have a sign-up sheet. How many people are allowed in the big classroom? Maybe I'll post a link to that, or maybe I'll make one. Researchers vaccinated mice intrathecally to stimulate inhalation of the vaccine so that it went directly to the mucosal surface of the lung. Interesting. They vaccinate intrathecally and that stimulates inhalation of the vaccine? I'm not sure what you're saying. So like it cause it to directly deposit? I'm not sure what you mean. Okay, so yeah, do you know how many are supposed to be allowed on into the big room? If you can tell me that, I can make a sign-up sheet and I'll just send it out on an announcement. 25% increase or 20 times increase in T cells in lungs comparison to I. Probably the same strategy of targeting metastatic melanoma. That's pretty cool stuff. Okay, 24. All right, it's about a third, a little more than a third. Oh, intratracheal. I'm sorry, I misread that. I thought you were misspelling intrathecally. I have intrathecals on the brain because I was working yesterday at the hospital, and so I was like, man, that's pretty invasive for a vaccine, but I'm interested. Pretty cool. Oh, you already have a class, right? Okay, so like, can you make one for me for tomorrow? Would that be useful? Poked in the neck. Well, intratracheally should just be able to go through the mouth, right? Like we do intratracheal meds occasionally, get intubation, but or ET tubes. Okay, so I guess I'll let y'all handle that, and then if you can figure out, hopefully, the injectum, geez. So if you guys can figure out the sign up sheet stuff, whoever 24 of you would like to show up, I plan on doing the same thing I'm doing today. Basically, I'll just be moving the location. Yeah, send me the article if you don't mind, Brian. So what I'm gonna do is get there early and try to do like a setup, so that way I can have like my camera just beam into me, and I'll just stream it up to YouTube. So whether you're on campus, off campus, I'll just be in front of some people. Okay, perfect. I appreciate that, Priya. Yeah, so you guys can do that, and then yeah, it should be good. I think hopefully. We're doing some errands at the hospital beforehand, so I'll probably be showing up in scrubs. So don't judge me for my poor dress, but that's okay. So anyway, we are late, so let's get started. I can go over that again later. All right, I had a couple of questions pop up on the sticky board, which you guys can see here. So someone said okay, so two of the questions are kind of similar to one another, I believe. Someone said, I'm a little confused about number 5 on the farm assignment. Can you elaborate a little more about it? How would you indicate when to stop the antibiotic treatment if you only give it for 24 hours? And then someone said on the assignment, it states cefazolin was given at 8. Is it safe to assume that it was given pre-operatively? Yeah, so going and looking at the assignment itself, so I have it pulled up here. All right, so we got our patient right, he's getting the procedure done. You know, most surgeries happen in the morning, so we'll just assume that that was when they got the first dose. So it was at 8 o'clock. That was the preoperative dose that they're getting there. And so, yeah, you have total control over this, right? You can say, like, how many doses of something you want someone to get. So if you say, for instance, let's say we want to do like a Toradol order, right? Let's say we wanted to do an order for Toradol. I'll increase my font here so you guys can see it. So if I wanted to say something like Ketorolac, we're going to do 30 milligrams IV Q6 hours, times 3 days. That would indicate on the system side, or on whoever's following that, that would indicate that they're getting 3 days worth. So 3 times 6, they'd be getting, or 3 times 4, I should say, because they're getting it 4 times a day. That'd be a total of 12 doses, right? You could also, instead of saying times 3 days, you could just do times 12 doses, and that would work as well. So you kind of have control of that if you want to set how long for something to run. But also, if I say, for instance, another key component too is, let's say, for instance, the patient got a dose of Toradol at in the ER, and they got it at like 11 o'clock in the morning, and I wanted them to start it. But I don't want, you know, if I wrote this and say, okay, so let's say it's they got dose at 11 o'clock, and then right now now is 12. So if I write that order like that, and I'm the admitting person who's writing the orders, that first dose could be given right at 12. It could just happen right away because I didn't indicate when to start it. So if I wanted to say, okay, well, let's start it at a later time, I could try to build that in. And so I could say, okay, well, if I want them to get a total of 12 doses, I could say, okay, let's do times 11 doses, begin at, or start at, let's see, so 11 plus 6, so 1,700 hours. So you could just say that. You say, okay, now I know that the order is supposed to start at 1,700 hours. They're going to be getting this many doses. This is how often they're getting it. Here's the dose. Here's the route. Here's the drug. Boom. That's a whole order right there, right? So that's what I'm looking for in terms of, I want you to be specific in terms of like making sure you're saying like, okay, this is how things are supposed to be done in terms of like being specific. And so that way, whoever's following that order, whether it's the pharmacist filling it, whether it's the nurse who's giving the med, it's very clear, because you don't want people to have to make assumptions about what you mean. And so the reason why I sort of harp on this now, before you guys are out there working clinically, is because I have to do this like every single day. Like every day I'm working, like it's something that we have to make sure we do to ensure patients are getting the appropriate antibiotics, to make sure they're not getting doses too soon, whether that's from a kid getting admitted from the ER to the floor, to make sure they don't get a medication too soon. I'll see this all the time where like a kid will get a dose of Rocephin in the ER. They don't need another dose for 24 hours, but then the admitting person just says, okay, 1 gram of Rocephin Q24, and it starts like 3 hours after they got the first dose. So at that point, I can't just assume that that's what they want, or I could assume that's what they want, even though it wasn't, and just process it, but then the kid would get double dosed on their Rocephin. That's no good. The medication error. So I have to be like intuitively think, okay, well, they probably meant to do this. Now I have to call them, because I can't just change it for them, because then that'd be me doing independent practice, and I'm not licensed to do that. It's just not within the scope of practice of a pharmacist. So by doing that, being specific, you head off a lot of problems in terms of like phone calls you're going to be getting from people because they're confused about your order, or you prevent errors from happening and making sure that your patient's being taken care of, because medical errors are super, super common, especially with medications there. So hopefully that makes sense. If not, you can let me know. On a different note, someone's asking about the MAC value. So we have a return of the MAC, so to speak. They're saying for nitrous oxide is greater than 100 versus desflurane, which is about 6. What would this mean? So if you kind of consider it, remember the MAC is that minimum alveolar concentration. So the concentration you have to get to in order for 50% of the people that you're giving the drug to not respond to noxious stimuli. So it would be if I was giving a certain drug and I had 100 people and I gave it that same concentration to every single person, and only 50% of them had no response to the noxious stimuli. That's the MAC, right? It's kind of similar to like an LD50. Like, what is the dose I would have to give to kill 50% of people that receive this dose, right? But it's more as an aesthetic concept than it is like a lethal concept. So what that means is that it takes a whole lot less desflurane in order to get that MAC, that minimum alveolar concentration, versus something like nitrous oxide. You'd have to give so much nitrous oxide to have 50% of people not respond to any noxious stimuli, that they basically be not inspiring any oxygen, and they would likely just not be responding to noxious stimuli because they're dead, because they're hypoxic, right? So from that standpoint, that's why you will see drugs used in different situations. So if I don't need the person to be completely unresponsive, like a day surgery, or like something's at the dentist office or something like that, then you can use some nitrous oxide, and that's fine. Like, you'll get some of the analgesic activity, they're going to be kind of out of it a little bit, but they can still breathe on their own. They can still be able to be somewhat responsive if you need them to. So that's kind of what we're getting at with that, is just to kind of give you an idea of terms of like how potent these agents are in comparison to one another, right? All right, how long of a stay do you want us to write the meds for in regards to the pain or nausea meds? That's up to you. I mean, like, you can write a specific duration on it, but when you are admitting a patient, so if you're the surgical PA working, you're going to be seeing that patient. It may be like one of your partners or somebody, but you're going to be seeing that patient. Presumably, that patient will be seen every day, so to speak. And so from that standpoint, you don't have to put stop times on everything, right? So for instance, if I go and I write morphine, Q6 hours, PRN, severe pain, or Q4 hours, whatever I want to do. If I put a stop time on that, that assumes that the patient's pain is going to be gone at that stop time. But instead, what I can do is put no stop time on it, and then I go back and see that patient the next day and say, hey, how's your pain doing? Talk to the nurse, see how often they're getting the drug. If they're getting it around the clock, then they're still in a lot of pain. So I'm going to keep that order on. Versus if I come in and say, oh, they've only used it once and they're doing a lot better, blah, 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 then maybe you can de-seed at that point. So if you don't put a stop time on a med, it will continue forever, presumably, till the patient's discharged, maybe. So those are things you want to consider. So certain things need a stop time, certain things don't, right? So in the case of the antibiotics, I told you do 24 hours worth. In the case of Toradol, don't do more than 5 days worth. So my morphine, you can keep it on forever, potentially. So probably not good for the patient, but that's how we kind of go through and do those sorts of things. So if you need a specific duration, then you can put one on. If you don't, then you can go back and see that patient the next day and decide if they still need it or not. Hopefully that makes sense. Anyway, let us finish up our content for the exam. This might be a shorter day. I think I'm gonna, if I finish this today, and then I will do the review tomorrow, and then we should be good. Because I think, looking at our topics for the rest of the section 4, I think I'll just pop the immunology or immunization lecture there, because Jerry's pretty quick actually. So we'll see how much we can fit in there. And so that should be good, I think. So it'll be 5 topics we'll be covering there. But anyway, so let's finish this up. So we are talking about local anesthetics. We kind of went through and talked about more general anesthetics. We talked about our inhaled gases. We talked about a lot of our sedation meds like propofol and ketamine and things like that. Now we can get into some local anesthetics, which certainly have quite a few benefits to them, mainly being that they really don't cause any change, or they shouldn't be causing any sort of change in terms of mental status. But we'll talk about how they work, how we use them, things like that. So nociception, right? What is that? Well, pain awareness, right? And so it's being mediated through your nerves. So if I cut your finger, you're going to have pain sensation that gets mediated through those nerves up into the CNS that says, ow, that hurt, pull your finger away, in order to avoid more pain. And so we can try to block that or blunt that through a couple of different ways. So for instance, like our opioids are working in the spinal column and in the brain in order to sort of blunt those responses coming in. It doesn't stop them completely. So, you might still know you're in pain, but you may not just really feel it as much in those cases there. But what if there's a way we could sort of just block the sensation altogether? Well, that's where our local anesthetics are going to be coming into play, because they're working locally. They're working out at the site in the periphery versus working within the CNS. And so that's going to be sort of the benefit here. And what they're going to do is basically they provide this reversible impulse conduction blockade, right? They prevent those pain fibers, those nociceptive fibers, from sending painful signals up into your brain saying, ow, that hurts, right? Interestingly enough, cocaine was the first local anesthetic we ever had. It's back in 1860 when they first sort of recognized it. I'm sure it's been used, in South America for a gazillion years before that. But when we first kind of recognized it, I think this might have been some German scientist or something that discovered its properties as a local anesthetic. And you can use cocaine nowadays as a local anesthetic if you wanted to as well, from a medical standpoint, because it's a C2. Like that's a valid medication you could order if you had proper reason to need it. So for instance, we carried cocaine for a short period of time at Nemours because some of our ENT docs said that they would like to use it for some of their procedures. I'll talk about some of the other things about that just a little bit, but they ended up never using it, so we kind of got rid of it. Not got rid of it, but we actually disposed of it. There's a whole process you have to do with that with C2s and whatnot. But anyway, and so again, if you ever watch like TV, it's probably sort of a dated reference, but if you ever watch like TV where there's like a drug deal going down and like someone is buying cocaine and they want to test it to make sure it's really cocaine, they'll rub it on their gums. And they're like, well, why in the heck are they rubbing on their gums? It's that anesthetic action. If they do that and they feel like their gums are getting numb, then they know presumably that that's cocaine. And always be the case. Sometimes they'll lace it with other things like benzocaine, for instance, which we'll talk about here in a little bit. But that's kind of that's the reason for that is. And so, cocaine obviously has some other issues associated with it, with some addictive properties and things like that. So we don't use that a lot for, typical lacerations and things. But it provided a good benefit because it had some local anesthetic action. It's also a good vasoconstrictor. So it kind of keeps, if you're, lacerating a wound or something like that, it keeps the field a little bit cleaner because you're not having as much bleeding and things like that. So those are some of the benefits of cocaine that they recognized back in the day. But what we're going to see is that, you have to use these drugs responsibly because they can be quite dangerous if used inappropriately. And I'll talk about some of the ways we can do that, because not only will they block nerve conduction of nociceptive fibers, but they can do the same thing in the brain, which can lead to things like seizures. They can do the same thing in the heart as well, which can lead to some pretty significant arrhythmias, which we'll get into a little bit later on here. So as I mentioned, they block reversibly this impulse conduction along the nerves. And you're going to see that, and I'll show you, I think I have a picture here in a little bit that demonstrates that. And you're going to see that they actually work within the cell membrane themselves because they're blocking the sodium channels there that are necessary to potentiate that action potential. To potentiate a potential, I guess. So what are the local anesthetics? And I think I have a picture of I guess I don't here. So anyway, and if you were to imagine, some saying, doesn't cocaine help with altitude sickness as well? I heard that's why people in Peru drink coca tea. I'm not sure how though. Yeah, so there is something to that. Part of that is that because it's a stimulant, it also stimulates your respiratory drive. So when you're going from, like, say, below sea level, like we are here in some places of Florida, to, a mile or higher, you don't have so much oxygen coming in. Like your hemoglobin just isn't, your whole circulatory system is not designed to deal with that low of a partial pressure of oxygen. So by stimulating breathing, you're going to be able to bring in more oxygen, and that can sort of help out with that. Kind of similar to how like acetazolamide is used similarly for altitude sickness, because it causes a little bit of a metabolic acidosis, which stimulates your respiratory drive. But yeah, beyond that, it also gives a little pep in your step, so maybe you feel less fatigued from not having as much oxygen as you're normally used to. But anyway, if you were to imagine a nerve and recall that it will send those signals down those nodes of Ranvier, if you remember looking at a neuron and seeing those little nodes that it can travel between, that is all sodium influx happening. This is sending that signal up the nerve and into the CNS there. So we're going to be blocking those sodium channels and basically deadening that signal to where you may have no sensation whatsoever. And I don't know if anyone's ever, gotten any kind of like anesthetic or something, but you can't feel anything, which is usually pretty good from a pain standpoint, right? And we're going to see that's kind of the benefit of using these anesthetics, is because if you can just deaden the sensation altogether, then you don't need to deal with things like opioids potentially. So these are very opioid sparing in a lot of cases, especially after like orthopedic surgeries and things like that. So I'll talk about some ways we can use that. So as I mentioned, cocaine, here's a picture of the coca leaf and some refined cocaine from, it's not my personal collection. I would never show a picture of that. But then we have things like prilocaine, mapivacaine, ropivacaine, bupivacaine, and then lidocaine. I think most people have heard of lidocaine. It's probably the most widely one you're going to see used out there, just in medicine in general. And so just to give you some ideas of sort of the differences between these, is that you can find that some may work better versus others in terms of like duration of action. Sometimes you don't need a very long duration of anesthesia. Sometimes you may want a longer duration of anesthesia. So for instance, if I was doing something like an eye exam and I needed to do like a fluorescein stain to look for foreign objects, right? You anesthetize the eye, and that way you can do the fluorescein, you can do all of that, so you can look for your foreign, if you need to remove the foreign body, you can do that too. But I probably don't want like a really long duration of action on the eye, because if you can't feel your eye getting dry, you don't have the impulse to blink, and so you can actually see issues like we talked about back in ophthalmology way many moons ago, where we talked about how that absent blink reflex, well, it may make the patient feel better. It's not ultimately good from that standpoint, because then they get further abrasions from not blinking and having debris and things like that in their eye. On the other hand, though, if I say, for instance, like had a laceration because, I don't know, I fell skateboarding or something, and I needed to have a bunch of stitches put in, maybe it's okay to have something longer acting that can stick around for a while. So that way, when I go home, I'm not like immediately going back into pain, and it may be longer before I need to utilize things like over-the-counter pain medication or something like that. So in that way, you can kind of see some of the difference here in terms of the half-life and whatnot. So for instance, things like ropivacaine and bupivacaine, they have a nice long half-life, so they can have their duration of action for, in some cases, like hours and maybe like a day or more, and depending on how you're using it. And also, you're going to find these drugs typically have a very large volume of distribution. They tend to, and that's good because they need to partition into the cell membranes of the nerves that they're trying to deaden in order to have their mechanism. So it does make a sense that they are quite lipophilic. That'll also become important when I talk about the reversal agent for these in just a little bit as well. But you can see some general differences here. I typically think about things like bupivacaine and ropivacaine being really the long-lasting ones. Lidocaine is going to be a little bit on the shorter side of things in terms of that. I'm not going to ask you specifically on the exam which one's longer or shorter, but that's just clinically speaking kind of what we see when we're using these. And again, you're going to use these a lot in surgery. You're going to use these a lot in the ER. You're going to use these in dermatology, depending on what you're doing. There's a lot of places you might see this pop up, even if you might not think so. Even if you're not like in a really procedure-heavy sort of discipline, you may still see these local anesthetics, which is why it's good to know about them. So their absorption we're going to see is going to be dependent on several things. So one's going to be the dosage that we're administering. Obviously, more of a dose we're giving in the periphery, the more it gets absorbed. The site of the injection can also matter as well. So depending if we're injecting, say for instance, I'm trying to think of some good examples of this. If we're injecting like in a very peripheral tissue, like the toe versus somewhere more centrally speaking, that could make a difference there. And then we're going to see some of the physicochemical properties can affect things like the drug tissue binding. So the tighter they bind to the tissues, the longer they're going to stay out in the periphery versus getting absorbed systemically. And then things like local blood flow, and along with that is the use of vasoconstrictors. The main vasoconstrictor we're going to see here is epinephrine, which I'm going to talk more about here in just a little bit. And so the more local blood flow you have, the more it can pick up those local anesthetics and then put them in the systemic circulation. And so if we can mitigate that, if we can try to decrease that with the use of things like vasoconstrictors that can keep the local anesthetic at the site for longer, so it's working longer, it can also help to prevent some of those toxicities. And I'll show you some examples of that in just a little bit. So as I said, they're blocking those voltage-gated sodium channels there, and they're going to be preventing, and it's kind of interesting because they work better on more active fibers. So if you're having tissue that's like actively in pain, sending a lot of signals, they work better on that tissue than if the tissue wasn't really sending a whole lot of pain signals in the first place. And so you can see that they will block the sodium channels, prevent the signal from being sent up into the CNS. And there can be some things that actually can affect how well these can work. So for instance, if you had like elevated extracellular calcium, like you have like hypercalcemia, it can actually sometimes antagonize that because instead of having sodium come in, maybe you have some of these calcium channels open up that can help to send a signal, help to potentiate the action potential. Or in some cases, if you have like elevated extracellular potassium, which would mean that you have less of it inside the cells versus outside, that can actually enhance the effect. So clinically, this doesn't come up all that too often, but it's kind of interesting to see how different ions can be playing a role here. And so what we're going to see is that when you apply the local anesthetic to the nerve fiber, you're going to have an increased threshold for excitation. It's going to take a lot bigger signal in order to elicit a action potential there. Things will slow, so again, they're not being sent up as quickly, and you're going to overall have a decrease in the amplitude of the signal, the actual rate of the rise of the signal, and to a point, you actually get just inability to generate an action potential at all. So pretty interesting stuff how it's able to work and prevent that any signal from happening whatsoever, right? And keep in mind, this is really just working on those nociceptive fibers, those sensation fibers. It doesn't work on things like, muscle, right? So you can still move the appendage. It's not deadening those action potentials, really just on those nerves that you'll see there. Because that'll be important because we're going to talk about paralytics later that specifically work on the skeletal muscle to inhibit those action potentials, and we'll see how those kind of work. And sometimes in tandem, but we'll kind of look and see the comparison between the two groups there. Yeah, so anyways, and again, that propagation along the nerve is just not possible because you have so many of the sodium channels being inhibited and no action potential can happen there. So as I mentioned, vasoconstrictors, I say as I mentioned a lot, and I guess I repeat myself, but with these vasoconstrictors, you're going to see they reduce systemic absorption by decreasing the amount of blood flow getting to the tissue by about 30% or so. And that allows for having higher local concentrations of those anesthetics there, which is good. And you can have fewer systemic side effects as less of it's being absorbed systemically. That allows you to give bigger doses. So if I had, say for instance, a very large area that I needed to anesthetize, I may want to use something like a vasoconstrictor to give myself allow myself to give more anesthetic than I would otherwise. So as an example, I don't know if I include the numbers later, but if you were to look at the max dose I could give of lidocaine while doing, say, a suturing, maybe it's something like 5 milligrams per kilogram is like the max dose I can give before I worry about systemic toxicity. If I combine that with epinephrine, so if you just see like lidocaine plus epinephrine compounded together, you can give like 7 milligrams per kilogram. So again, it bumps up your dose in terms of how much you can give. That way I can get more anesthetic depending on how big of a site you need to give there. So in addition to that, you're going to also find that it will help out with the vasoconstriction, so you get less bleeding. It'll keep your site cleaner, so that way you're able to do your work a little bit easier than having a bunch of blood in the way, things like that. So that is another benefit. Keep in mind, though, one thing I did not write there here specifically is that just be cautious, and you don't want to use vasoconstrictors like epinephrine in sites of terminal blood flow. Terminal circulatory flow. And what I mean by that, I think you guys might hear this in your surgery section with Professor Gardner, perhaps, but it's fingers, toes, penis, and nose. Those are the places you don't, and it sounds kind of silly, but those are the places you don't want to use vasoconstrictors because at those terminal circulatory sites, you're not going to be able to get enough oxygen coming in, and that can lead to some issues in terms of like tissue necrosis and things like that. So obviously, wouldn't want to do that in the nose because, want to keep a nose on your face typically. But, I run into issues like this from a toxicology standpoint where people will have EpiPens at home, EpiPens or epinephrine, and they'll accidentally inject themselves in the finger, and all of a sudden it gets like super blanched, gets really cold, and they can't feel anything because there's just like no blood flow coming in. And we have to use things like hot compresses to try to increase the absorption. We have to do things like use a drug called phentolamine that dilates those vessels. It's usually not a good thing when that sort of accidental exposure happens. So that's basically the takeaway. The vasoconstrictors are good because they allow you to use more local anesthetic at the site. They decrease bleeding, but you don't want to use it in those terminal areas. So fingers, nose, penis, and toes. Those are the big four that I would not want to use them in. So anyway, so again, what you're going to find is that the more lipophilic ones tend to have like an easier time getting in and interacting with those sodium channels there, and that kind of helps out with some of the potency of the agents there. So more lipophilicity helps get them to be more potent. So you need less drug in order to get the same effect. So things like lidocaine and procaine and mepivacaine tend to be a little more water soluble, but you're going to see that things like tetracaine, bupivacaine, ropivacaine tend to be a little bit more potent and longer lasting in terms of their duration. So a lot of our we used to have like a suture. We used to have, I think they called them like the Boo Boo Care Team or something like that. There's a group of paramedics, and I'm not sure if they still have it or not in the ER, but they had a group of paramedics who were trained on how to do suturing to kind of relieve their other providers to go see more patients and whatnot. And they really like bupivacaine because of the long duration. So the kid went home and they didn't really have a lot of pain come back until maybe the next day when they could, pain was reducing anyway, and they can start to use some over-the-counter pain meds there. So. How we frequently give this includes topical. So things like, we may see topical application of things like lidocaine jelly. You'll see this used via injection. And so this is typically going to either be at the site of pain itself. So you can do things like local blocks that can be done. So if you have like a hip replaced, you may be able to apply the block there locally. And that's, again, when I say block, it just means it's a nerve block, meaning you're giving the anesthetic to decrease the sensation from those fibers. Or you could do it in things like epidurals or subarachnoid spaces. We touched on this briefly in the OB-GYN section when we talked about you talked about using epidurals for during labor, right? Marley's saying, so those bottom options would be more lipophilic because they are more potent. No, they're more potent because they're more lipophilic. They're more easily able to interact with the cell membrane itself, right? Because the cell membranes, it has that phospholipid bilayer, and it's all lipophilic on the inside of that core of that. So again, it gives them an easier time to get in there and interact with those sodium channels, right? And then occasionally you're going to see IV use. This is primarily just going to be with lidocaine, like we've talked about with our antiarrhythmics when we were doing cardiology last semester. And recall, like the reason why lidocaine works as an antiarrhythmic is because it blocks sodium channels on the heart. What you're going to find, though, is that this can be really problematic when you're using really lipophilic meds like bupivacaine, because once something like that, if you were to accidentally give it IV, once that gets locked onto the heart and it's really lipophilic, it doesn't like to come off. And so obviously blocking all those sodium channels in your heart could lead to things like, having a ventricular arrhythmia or no heartbeat at all. And so accidental exposure to these IV or accidental IV exposure to these local anesthetics can be quite problematic from a cardiac standpoint. I remember a trick my dad used to tell me. So my dad's a CRNA. He worked in L&D, labor and delivery, for 20 some odd years or something. And so he would talk about when he was doing his epidurals, one of the tricks he would use to make sure that he was actually in the epidural space and not accidentally somewhere else or accidentally injecting it, intravenously on accident or something like that, is he'd give just a little bit of epinephrine. And if he saw that the heart rate went up, then that would be a sign that he was not really in the epidural space, because it shouldn't really be affecting the heart if it's just there in the epidural space. And if he didn't see that, then he knew he was in the right spot, and then he knows he can go ahead and give his local anesthetic. Otherwise, if he was accidentally infusing that drug systemically, then that's going to lead to all kinds of problems like we're going to see here in just a little bit. So how do we choose our local anesthetic? Typically, we'll base it on the duration of action that's required. So for instance, like we use a lot of Procaine in our for eye exams in the ER, for instance. That's one thing, because you don't really need it to last that long in a lot of cases there. Intermediate acting may be better for things like dental procedures, or if you're doing things like suturing or things like that. So lidocaine, bupivacaine might be really good options for that. And then for long acting ones, we typically see things like bupivacaine, ropivacaine. Those are the two of the big ones I see most of our surgeons use. Drugs like tetracaine will sometimes use for some eye things. Then levobupivacaine is another option you might find out there as well. So again, those are longer lasting. They're more lipophilic. It tend to be more potent. So it kind of go hand in hand from that standpoint. Sometimes you'll find combination products, which is kind of interesting. So you can see that you may get more like kind of fast, short action from the lidocaine, and then the bupivacaine kind of brings up the rear by it being longer lasting. So there's an option called a duocaine you can use for injection. It's the combo of the two. Or we use something called an IMLA cream very frequently for things like needle stick analgesia and things like that, or if like a patient has like a port that's placed for central line administration or like central access, we'll use something called IMLA cream, which stands for eutectic mixture of local anesthetics, which is a very interesting kind of thing if you're into like chemistry. Basically, a eutectic mixture means it's two things that they lower each other's melting point when mixed together. So it's kind of interesting. I had to one of my dosage form classes that I had in pharmacy school, the teacher actually demonstrated this in live, where he had like solid lidocaine and solid prilocaine. He was like mixing the two together, and then as he did, they both like kind of turned more liquid because they were kind of reducing each other's melting point. So little weird pointed trivia there, but we use this as a cream a lot, and we'll place it over a vein, so that way that we can get analgesia there, so the patient doesn't feel when you're getting their IV started, right? For like kids are especially needle phobic, as an example. So in terms of toxicity, the things we want to worry about include the systemic effects, because they can affect the brain, they can affect Allison, you don't have to humor me. I understand when things are not cool, and most of the things I say are not, okay? Just kidding. anyway, so the systemic issues are going to be a problem here because if you have systemic administration of these drugs, they can affect the CNS, where you have a lot of sodium channels responsible for, having a nice organized, firing of your neurons in order to be able to think and exist. And then you'll also see from the heart standpoint as well, you're going to lead to some issues there. So you have to worry about the neurotoxicity primarily, and then we're also going to see the cardiac toxicity are going to be the big problems there. Okay, so those are things we're going to be looking for. Those are the kind of the issues we're going to be seeing as being most kind of dangerous. How those CNS toxicities can manifest include things like you can have some depressed mentation, so they're kind of sleepy, might be kind of lightheaded. Frequently, they'll describe either like tongue numbness, and you're like, wait a second, I'm injecting this somewhere else. Why is their tongue all of a sudden going numb? That's a sign of systemic toxicity. Or they may describe sort of a metallic taste in their mouth. And again, even if you haven't sucked on a quarter recently, I'm sure you can imagine what a metallic taste is. It's not really normal, right? I only mentioned that because of my actually, it's funny, like my kids came home after like St. Patrick's Day, and they had these like little quarters that were covered in foil, and inside there were chocolate. And I was like, oh, that's fun, because I imagine some kids are going to eat like an actual quarter and think they're all chocolate. And sure enough, I saw a kid at the hospital who was going in for an endoscopy because they had eaten a quarter. So it was not making me happy as a toxicologist, but anyway. Other things you can see too would be including things like nystagmus, muscle twitching, and then it can manifest all the way as tonic-clonic convulsions. So again, things to certainly want to avoid. So if you can see things like, okay, they're getting this tongue numbness, maybe I should back off. Maybe I should hold off and not give any more of this drug here. Those are things you want to be thinking about, right? Now the cardiovascular toxicity as well can be really problematic because, especially bupivacaine, I think this one has sort of the most experience and evidence with, but you'll see it tends to be more cardiotoxic because of its long-acting nature, because it is so lipophilic. You're going to see this like really broad and QRS complex as it slows down sodium channel conduction in the heart. And so what's really interesting is the way that we actually treat that. And so I have a bag of intralipid here. I'm sure like someone like Shelby will be familiar with this, but this wrapper won't come off. Oh well, down the hatch anyway. I will tell you, my child this morning just says she had a quarter in her hands. I was teaching this morning. I came out of my room and she's like, "Oh, this quarter, there's chocolate in here. Can you unwrap it?" And I go, "That's a regular quarter, sweetie." She's like, "No, there's chocolate in here." I go, "There is not. Do not swallow this thing, for the love of all things holy, because I don't need another kid to go in for foreign body ingestion after Phoebe ingested her bobby pin." Priya saying, with the side effects occur when you're given the drug or occur later? It depends. A lot of times, yeah, Lily was testing me. I don't think so. Oftentimes you're going to see the toxicity happening during the actual infusion, but it depends how you're giving it, because some of these local nerve blocks, or like, if you had an epidural administration, those may be being given for a long period of time. So you could see that they were, given over the course of hours. So you may like start the drug, walk away, and then the toxicity happens. Or if you're actively like giving it, if you're doing a procedure or something, you may see it right in front of you. So it sort of just depends there. But anyway, so what's kind of interesting is that, and there's a lot of really good case reports about this, but if we have something called the lipid sink, where basically if we have this intralipid, which is normally used for parenteral nutrition, and so like if you had a patient who's getting, say they couldn't take anything orally, you still want to give them nutrition, you can give them a parenteral nutrition, and that includes amino acids, includes carbohydrates, as dextrose, and includes usually some amount of fat, and it comes as this intralipid. It looks like milk that you're giving IV. But what we can do is give the intralipid IV, and it allows for sort of this third space. It's very lipophilic, for the bupivacaine to come off of the heart and into the intralipid and allow your body to process it and then eliminate it. And so we have this for all of our patients who get like epidurals or caudal blocks and things like that, for orders for intralipid in case they develop any sort of cardiotoxicity. So that way they can go get it, give the intralipid, and save the life. And if you ever want to see some really fascinating case reports, look at things like look up like cardiac arrest and intralipid, and you'll see cases where patients had accidentally, these patients were like coding, they were in cardiac arrest, they've been coded for like 20-30 minutes or something, to where a point you're like, this person's dead, there's no way they're coming back. Someone has a bright idea to give the intralipid, all of a sudden they come back, they have a return to spontaneous circulation. It's really fascinating if you go look at the case reports. So anyway, so that's kind of the standard treatment if you were to have cardiac toxicity associated with something, especially with a more lipophilic anesthetic like bupivacaine. So that one just kind of comes to mind because there's a lot of research with that. The original guy who did the research for this was doing it with like rat hearts, and he had these like little rat hearts that were set up, and he'd like infuse the bupivacaine, it would stop, and he'd give the intralipid and start up again. It was kind of wild, but other things you can see less commonly or would be methemoglobinemia. And so this is where you have some kind of strong oxidizer on board that is changing your oxyhemoglobin, and it's basically oxidizes the iron into, it goes from a 2+ state to a 3+ state. If you're interested in the chemistry, that makes it less likely to bind to oxygen, but what it loves to bind to is water instead. So obviously that sounds like a problem because now your hemoglobin is carrying water instead of oxygen. And so you can get this really cyanotic appearance from that. The venous blood will look very dark, sometimes chocolate colored is how they'll describe it. And really the big one that causes this frequently is benzocaine. And this is the thing I've run into most frequently as causing this. There's something called Cetacane or hurricane spray. Kind of fun because, hurricane, live in Florida, I guess that makes sense. But we will frequently, if we need to give something like, if we need to administer like an NG tube or something, right? Typically, when you are administering the NG tube, you want to anesthetize the back of the throat so that way the patient doesn't have their gag reflex activated, and you can get that placed a little bit easier. And so we'll use something like hurricane spray to spray in the back of the throat to anesthetize that. Well, you have to make sure the people who are administering know not to just like keep spraying, because some people will like use the full bottle in that patient. Getting that much benzocaine in is what causes the methemoglobinemia. So all of a sudden you have a patient who's cyanotic, and you're like, oh crap, this person's not breathing, but they're sitting there just kind of acting normal. But it's because they had this methemoglobinemia. So, and they can actually tolerate pretty high levels of that before they really become hypoxic from just lack of hemoglobin available to bind to oxygen. But anyway, this is the main drug that causes that. Yeah, so use hurricane spray when doing biopsies in the mouth or lips. Yep, there you go. Yeah, so from that standpoint, yeah, you have to know like not to give too much, because otherwise you may run into an issue of this. Jackson's convinced I could tube myself with a glide scope and some hurricane spray, but no one will let me try. Well, I will not be one to let you try it today. Maybe with some of your other professors will give you a chance during a sim day or something like that. Actually, I did a whole case report just on, or not a case report, did a whole grand rounds just on this drug called methylene blue, but this is the treatment of choice for methemoglobinemia. It's actually a blue dye that you can give to convert the methemoglobin back into the normal oxyhemoglobin, basically, and it will allow it to bind to oxygen again. So it's a pretty interesting drug there. So you give the blue drug to the blue patients, and they turn them pink again, basically. That's how I remember. Isabel saying, is there a sulfa compound or component, because we used to ask if they have a sulfa allergy? I'm not real familiar myself. I don't think there is, but maybe some of those products might have like a some sort of adjuvant in there, some sort of other compound other than the local anesthetic. That might be what you're seeing there. Yeah, so anyway, let me see. Someone had a question over here. Someone was asking, toxicities can happen only if you give these local anesthetics via IV. Not necessarily, right? So if you're giving something, let's say I have a, something like a laceration to my arm, and you're trying to sew up my arm. If you're infusing a ton of drug there, if you're injecting a bunch of drugs, some of that is going to become systemically administered, right? Some of it's just going to get absorbed naturally. So if you're giving too much, even in the periphery, is where you can see that. You're more likely to run into those major toxicities if you accidentally give something IV when you didn't really mean to. So that can be the thing you would see with that. So it can still happen. That's why there's max doses you'll see, like when infusing or when you're giving something like lidocaine for a laceration repair. There's max doses, because if you go above that, the risk for those systemic toxicities tends to be a little bit higher. Some said, would intralipid only be effective in those who have cardiac arrest secondary to anesthetic toxicity, or are you referring to random cardiac arrest? In the case reports, you'll see it had to do specifically with anesthetic toxicity. There are other case reports where people have tried it for other lipophilic drugs. So some people have tried it for like TCAs and stuff, but it wouldn't, if you just had a random patient with cardiac arrest, I would not just give it to them. Otherwise, it really wouldn't be expected to do much. But these were cases where patients had accidentally had local anesthetic toxicity specifically, and they were able to bring them back. So it was pretty cool stuff. I think Weinstein is the guy who did a lot of the research on that. So if you can look up his name too. And there's a whole like lipid rescue website where they talk about the protocols and everything they do for that. So anyway, so lot of talk about this slide here, but these are the main things to take away is that, again, the cardiac toxicity, especially for lipophilic local anesthetics, can be reversed with intralipid. And be careful using things like benzocaine because you can cause methemoglobinemia. And I can probably put a vignette on the test to say, like, okay, a patient recently had an NG2 placed, all of a sudden they're cyanotic, and the nurse says they have chocolate-colored blood. What do you want to give to this patient, right? You have to recognize, okay, that's methemoglobinemia, probably related to local anesthetic toxicity. What do I give to that blue patient? I'm going to give them methylene blue. That'll fix it, right? Versus like flumazenil or Arcan or something else, some other kind of reversal agent, okay? Anyway, so when you're looking at anesthetics, there's two main sort of chemical delineations to make. So there's between the amides groups, and again, it has to do with their chemical structures, the amides, and then there's the ester local anesthetics. And again, the reason why I'm boring you with the distinction here is because you will have patients who will complain or say that they have a history of allergy to local anesthetics. And if they're going to have an allergy, they're more likely to have it to one of the amides than the esters. So here are the amides. You have lidocaine, bupivacaine, mepivacaine, prilocaine, atidocane. And then you have here the esters, procaine, chlorprocaine, chloroprocaine. Geez, I can't even say it today. Chloroprocaine, tetracaine, cocaine, and then benzocaine. So how can you tell the difference, right? Very easy way to tell. If there is an I before the cane, then you know it's an amide. Amide, I before the cane. You can remember that, then, okay, you have a patient who says, okay, I have an allergy to benzocaine. I can't receive it. I have an anaphylactic allergy. You can give them an amide. That's okay, because structurally speaking, they're different enough to where they shouldn't have a cross-reactivity. Okay. Now, someone said, oh, I have an allergy, and so what happened is I went into cardiac arrest. Well, maybe you should find out if it was actually like local anesthetic toxicity versus allergy. But you get my point here. So again, being able to detect the difference here. So if I said, oh, a patient says they have an allergy to bupivacaine, which one of these would be safe to administer? You'd be able to recognize, okay, that's an amide. Let me go see which one of these are esters. So find one of these, and you're probably good to go from that standpoint. I wouldn't give your patients random cocaine unless they really needed it for like a. And again, our ENT docs liked it from that standpoint because they wanted to use it for certain procedures where they get good anesthetic actions and also the vasoconstrictor properties. So that way they didn't have to use epinephrine. Again, they never ended up using, so we ended up getting rid of the cocaine. But so I'm sorry, I misspoke. So the allergies are more common to the ester class. And so if you have a patient who's allergic to the ester, you can switch over to the amide class and vice versa since the cross-reactivity is so low. One of the things you're going to find, though, is a lot of times patients will complain of, oh, I got like Novocaine, which Novocaine's a brand name. But they'll say, oh, I have a Novocaine allergy. And you try to figure out like specifically which drug they got, and they have no idea. So frequently they just know it ended with a cane, and that's all of them. So it's kind of the problem there. So you may have some challenges from that standpoint. Another thing to consider too is that sometimes people have a reaction to not the local anesthetic, but it could be the methylparaben preservative. So this isn't, I don't think this is related to sulfa at all, but maybe that's something you might be thinking about, Isabel, with your question there. But anyway, that preservative, if you can get them a preservative-free product, then that would be fine. You can then get around that from that standpoint. And really, anytime you're giving something like intrathecally or into the spinal column, you always want it to be preservative-free anyway. You always want to be as clean as possible because since the intrathecal space is so protected and so kind of a sequestered sort of area. So anyway, so here you can see just as an example of comparison between the drugs here in terms of like duration of action, things like that, clinical applications. These are kind of the things we're looking at. So just to give you some ideas in terms of a summary. Cocaine, as I mentioned, just kind of nice because it has additional sympathomimetic properties, but again, you're not going to see it used very frequently unless maybe you work in ENT. I've never seen anyone else ever request it, but those would kind of be the big differences. Again, I'm not going to ask you which one's longer or shorter acting, probably. I'm probably going to be more specific talking about like toxicities, how to manage them, why you might or might not use a vasoconstrictor, what are some of the limitations on that, different concepts like that are mainly what I'm going to be focusing on there from that standpoint. So if you're not asleep yet, I can now finish up by talking about a couple of sleep agents that may be able to help you out if I was not a good enough cure for insomnia already. Although I'm sure some of you probably listen to my YouTube videos and help you drift off to sleep. All I need is like a lo-fi beat underneath me droning on about these drugs, and I guarantee you I could have like 1 million views on YouTube. It'd be pretty awesome. Maybe I'll try that after this. Who knows? There you go, because that's already asleep. She fell on the Z key. Anyway, so looking at sleep, this is, I'm sure some of you even have sleep problems. Some of this is related obviously to psychiatric issues. Some of it's related to anxiety, stress, things like that. But a lot of people have sleep related problems, right? Some people have problems staying asleep. Some people have problems getting to sleep. Sometimes it's a combination. Some people fall asleep at random times a day, and we have drugs that we can actually use for that as well. Usually you're going to find things that can also affect this includes excessive caffeine or nicotine intake. Lo-fi pharma beats to study and chill too. I'm telling you, this could be good. I just need like a cartoon rendition of my face or something. We can get that going. Anyway, so oftentimes you want to look to see what specifically is the problem here. It's like when are they ingesting caffeine? Are there any other substances they're using? It's kind of funny because you think about excessive ethanol intake as being something that would put someone to sleep, but oftentimes you're going to find that as they start to sober up, they start to lose that extra sort of like GABA activity, and their brain gets kind of too active and so have a hard time being asleep. So alcohol can certainly kind of be a double-edged sword from that standpoint. Okay, so probably a silly question. There are no silly questions here. What are the sympathomimetic effects that cocaine has, right? So when I say sympathomimetic, it means just mimicking the sympathetic nervous system. So cocaine is a stimulant. Basically, it causes blockade of reuptake of things like dopamine, which is why it's sort of why it's addictive. It can also cause blockade of reuptake of things like norepinephrine and epinephrine and catecholamines like that. Which is why you find patients who ingest cocaine, whether they insufflate it, which is a fancy term for snorting it, or they inject it, or whatever they use, you will find that they will typically be hypertensive, tachycardic, very alert, very, sort of just, they look very sympathomimetic. They look like they're in a fight or flight response, and that is the sympathomimetic effects that cocaine has. Its use as an anesthetic, though, is that you can get some good vasoconstriction from that if you were to inject this locally to do something like a suture or do some kind of a small procedure or something like that. So those are the effects that they're looking for, is the vasoconstricting actions of that from that standpoint. So you said that the allergy is more common with amides, but the slices esters. Yes, I misspoke on that. So it was actually the esters are more common than the amides. I apologize for that. But PoBuddy is Nerfic as it turns out, me included. Okay. So anyway, so again, you always want to get a good history, and people are complaining of sleep issues. Like, try to figure out, okay, is it a problem where, maybe their environment's not really suited for sleep? Perhaps they have, a screen blazing in their eye for 9/10 of the day, and they have a hard time sleeping from that standpoint. And again, just figure out about general sleep hygiene. They always talk about only using the bed for sleep and sex, and that's it. But people watch TV in there, or they'll eat in the bed, and all kinds of stuff, and things like that can be kind of problematic. I'm certainly no person to try to tout good sleep hygiene. I probably have pretty poor hygiene, staying up late, and grading and doing lectures and playing games and all kinds of stuff. But regardless, if you can help them to get like a regular bedtime and wake time, that can be somewhat useful as well. So that way they always know, okay, it's 10 o'clock, time to go to sleep. I think it's kind of neat nowadays that most of our devices already have a built-in blue light filter. You used to have like custom apps that did that, but now they can kind of cut down on that really harsh blue light that can kind of affect your ability to go to sleep. Exercise can certainly be a huge help here as well. And then try to eliminate any like caffeine use, nicotine use, or alcohol use kind of closer to bedtime there, and avoid liquids so that way they don't really get up and have to go pee a bunch in the middle of the night there. It can always be useful. So our sleep aids, what are going to be useful here, are going to be what they're going to try to help us to do is, one, ideally we'd like to correct the underlying issue, right? Then we'd like to be able to consolidate sleep, meaning that they go to sleep, they stay asleep, they don't have a bunch of like kind of broken up issues where they wake up multiple times during a night. I always have a terrible time. Anytime I have to wake up to go to Nemours, I have to get up at 5 o'clock in the morning because my shift starts at 6. So I'll go to bed at like 10 or 11 o'clock at night. And I'm so worried about, because I'm my type A personality, I'm so worried about missing my alarm clock that I wake up like every hour just to make sure it's not 5 o'clock yet, which is really my just dumb brain doing that. But that's, not very consolidated sleep, as you know. And so obviously we want good daytime functioning to come along with this as well, because you don't want a sleepy pharmacist verifying your orders, right? You want to make sure someone's nice and alert. That's where caffeine can definitely come in and help here. With our medications, though, most of these are going to be habit forming. Some of these may have some risk for abuse and addiction associated with them. So you want to make sure that you're using the lowest dose possible for the shortest period possible. Okay, that's really the big takeaway. You don't want people to get really habituated on this and need it all the time in order for them to get to sleep. Kind of similar to like our stimulant laxatives. You don't want that to be the only thing keeping them going to the bathroom, because they're going to be dependent on it at that point. So we have a couple of options here, and your options as a PA has actually expanded ever since the passing of the bill that allowed you to prescribe controlled substances, assuming you have a DEA license. It's within your scope of practice. So like the derm person writing for sleep meds is probably not going to be a good idea, because that's not really within your scope of your practice there. But if it makes sense, maybe your family practice or primary care or something like that, that makes sense. But before we get into the controlled substances here, which a lot of these will be, we like to focus on the simple things first. And so really antihistamines are a good option here, right? So again, for short-term use, you can utilize the first generation antihistamines. We don't like second generation because, if you recall, things like cetirizine, fexofenadine, loratadine, they don't cross the blood-brain barrier, so they don't really cause any sedation to any appreciable degree. So you really want to focus on your first-gen drugs like your diphenhydramine, doxylamine, which is marketed as Unisom, like that's specifically what it's marketed for. These tend to be the most common ones you're going to run into. However, they tend to be a little less effective than your benzos overall. Okay. They also, you're going to find the anticholinergic side effects in the elderly are not ideal. You can definitely cause worsened memory, more memory impairment. You can cause issues in terms of like dementia, and it's just related to the meds themselves. And we'll talk more about that in the geriatric section coming up later. Antidepressants can sometimes be used here. This is good for patients who may have like a history of substance abuse, who you don't want to give a controlled substance to, because these would be would not cause any sort of addiction potential. So things like TCAs, like doxepin, has been utilized for like sleep maintenance insomnia, so keeping people asleep for longer. TCAs tend to be pretty sedating anyway. Trazodone is another really good one, and again, I would see this quite frequently for PAs and NPs in Florida specifically, who did not have capabilities to write for sleep meds that were controlled substances. They would write for trazodone quite frequently. Just be careful. You don't want to like double up, and if someone's on like sertraline and then during the daytime for their depression, anxiety, you don't want to give them trazodone or TCAs at night, because that could then lead to things like serotonergic toxicity. So I'd be cautious with that, but that could be useful for patients who may have a history of substance abuse issues. Someone's asking, are the anticholinergic effects of antihistamines limited to the elderly? No, they just it's more pronounced for them. They're just more likely to see issues with that. I mean, if you imagine giving an antihistamine, like if you give Benadryl to, say, a typical adult, they may get a little sleepy from it, but you're not really going to see any kind of altered mental status. As opposed to some elderly patients, they can get really loopy while on those. And not only that, but also you can, all the other anticholinergic effects that go along with that. So things like, constipation, things like, dry mouth, all that goes along with that are things that are more pronounced in those elderly patients, right? However, it is kind of interesting because patients who suffer from bedwetting, actually they use imipramine, which is a type of TCA. That's actually one of the first line drugs they use for that. So it sort of makes sense, because TCAs also have anticholinergic actions that would prevent the patient from needing to pee as much, because your bladder's holding on to more, just like we use anticholinergics for incontinence, like we saw in the previous lecture. So again, kind of all this makes sense if you understand the mechanisms for the drugs and what receptors they're affecting. They can give you an idea for why we're using them for what we are, right? So a couple of different options we have available to us here include suvorexin or Belsomra. This one's actually interesting. It's kind of a novel mechanism here where it's affecting the orexin A and B receptors and it's antagonizing those. What's interesting with this is that it doesn't induce sleep necessarily, but it turns off this like wake signaling that you have. So if you had a patient who maybe had less of a problem initiating sleep, but maintaining sleep was their main problem here, this would be a better drug for them, because it basically maybe I could benefit from that when I'm waking up at 1, 2, 3, 4, and then finally 5 o'clock to get up for work. Obviously for most of these drugs here, somnolence and daytime grogginess is going to be like the biggest side effect, and they just need to really kind of play with it to see what's going to work for them, what doses are best for them, because if I needed to sleep better before I go to work, go to my other job, I shouldn't say, because this is my work, this is what I love to do, it just doesn't feel like work. But before I go to the hospital, I would not want that to be the first night that I take a sleep med, because if that makes me sleep through my alarm, that's going to be a bad thing, right? I won't be there to take care of the pharmacy. So that's going to be the kind of the most common thing you're going to see with most of these agents here, as we'll see. But interestingly enough, this suvorexant can also cause some rare things like, sleep paralysis, which sounds terrifying. I would never want to use this. Cataplexy, and then like kind of narcolepsy-like symptoms. Maybe kind of like inappropriately falling asleep at certain times, things like that during the day. So again, I don't see it used too frequently, but may be useful for more of that maintenance of sleep in a lot of cases. Next up, we have Remeltion, which is a Rosarum. This is a melatonin receptor agonist. And again, I'm seeing a ton of melatonin use, especially in children nowadays. I know my kids, they help them go to sleep with some melatonin, usually pretty low dose stuff, but basically the melatonin receptor is responsible for helping out with regulating that circadian rhythm, especially with sleep onset. It has a lot to do with things like response to like daylight and things like that. Your pineal gland is responsive to things like daylight. So especially when we had daylight savings time, where we spring forward, all of a sudden it doesn't get dark until like 8-9 o'clock. That for them, that means like, oh, I get to stay up until the sun goes down. And we're like, no, you still need to go to bed at 7 o'clock, and they don't get it, right? So sometimes some melatonin can certainly help there. It would be a prescription product as opposed to most melatonin just being a dietary supplement, to where they could activate the same receptors basically. And so it's good for more sleep onset insomnia in those cases, right? So now you can start to kind of delineate between, okay, which one of these is better for helping someone get to sleep versus staying asleep. Here's already 2 examples where we can kind of focus on those differences there. In terms of like side effects, mostly just kind of daytime somnolence is usually what we're going to run into. Okay, so next, now we're getting into the controlled substances that are utilized for sleep, and so this is including our benzodiazepines. So really anything activating the benzo receptors or helping GABA to work better is going to be able to be used for sleep to some degree, right? Which makes sense because of the fact that, by depressing those nerves, by causing them to be more hyperpolarized, you're going to have sedation, just like we see for seizures. Just like we see for anxiety, this can just chill you out, depress the CNS enough to where you can go to sleep. Interestingly enough, though, the FDA does put some warnings on these drugs because of some of the complex sleep behaviors that you can have, which I'll talk about more specifically with some examples I've heard from people. A few drugs coming up, but this can include things like sleepwalking, very scarily sleep driving. They may do things like call people on the phone, or they may go to their fridge and find out the whole thing's been cleaned out because they were sleep eating. Very interesting kind of things can happen when patients are taking these and then going to sleep, basically. The other big issue too is, again, you can develop that physical dependence, and addiction is certainly possible. So the majorities are going to be a C4. So that's going to be one restriction in terms of their use. And again, for a long time, like PAs and NPs just couldn't write for these. But now that has changed. And so your repertoire of drugs you can use for sleep has now expanded to some degree here. Someone said, melatonin always gives me nightmares. Is this a common side effect? If so, why? I don't know. Okay, so and then is Remeltion more potent than regular melatonin? So again, with something like Remeltion, at least you're always sure you're going to be getting a consistent dose. Again, with a dietary supplement, it may be a little bit more hit or miss because it may not always be as consistent in terms of like their production and things like that. Certainly, there's some regulatory stuff, but it's not done by the federal government. So I wouldn't say it's stronger necessarily, but it is a prescribed medication that you could use maybe if they weren't getting enough effects from their melatonin, I guess. I just see a lot of people use melatonin nowadays. I mean, we'll give kids up to like 10 milligrams sometimes. That's just what their home dose is. So it's pretty wild how much they really get. So melatonin gives me nightmares. Actually, the first time we gave my daughter Lily melatonin, it was probably like a year or two ago. We gave her, I think, 2.5 milligrams, and that she actually woke up screaming about. She had a nightmare about dinosaurs after, and she never wakes up with nightmares, and so we actually experienced that to some degree. We gave it a rest for a while, and then we tried again with like just 1 milligram, and that worked fine. She gets a little cranky, and we know the melatonin's kicking in, and we put her to bed. So I don't know why that happens necessarily, but yes, I have at least some personal experience just with my daughter having that happen one time. So I'm not really sure why, but it's an interesting side effect regardless. I mean, not interesting if you're not having the nightmare yourself, right? Now, the pillows in the oven and purse in the freezer. I've not seen that movie in a long time, but I'm sure if that's happening there, there's been cases of very similar things or worse things happening in some cases. Someone said, so if someone's having trouble sleeping due to nocturia, for example, what may be helpful for that? Yeah, so in those cases there, you want to figure out why they're needing to go to the bathroom. So is it to where you're having cases where they're drinking too many fluids close to bedtime, or are they on like a diuretic? Are they drinking alcohol, which is a diuretic as well? If it's just because of just nighttime bedwetting, like you would see with a child, then in those cases, something like imipramine or a TCA is actually pretty good for that. So an anticholinergic. You could probably try an antihistamine, which has anticholinergic actions, but from an actual what's done most commonly from a prescription standpoint, like imipramine, I think is what I see most frequently there. So as possible OD on melatonin to a life-threatening extent. I don't know that I've seen any case reports of anyone actually ODing. And again, I apologize if I'm going off on tangents here, but I like to address your guys' questions. Let me see real quick. I don't know if I have Lexi Tox on here. I don't know if melatonin has like an actual LD50. It's probably like nitrous oxide or something we're taking so much. Yeah, it doesn't even come up here. I don't know that I've ever seen or heard a tale of a fatal melatonin overdose. If anything, I might expect if someone had that much on board, they might do maybe like a trauma sort of case, or like maybe they decided to get behind the wheel of a car or something, and then drove and got into a car wreck, right? That's the only thing I would really kind of think of from that standpoint. Nothing specific. Yeah, so I don't know. Any cons to using melatonin chronically? Not that I'm aware of. I mean, it's not really like habit forming like you would see with something like a benzo, but I could imagine that you do develop some sort of like habituation with it to where if that's your routine, all of a sudden that throws you off. You don't have that normal sort of like onset of sleepiness due to that melatonin. Then you could see maybe some insomnia from that, but you don't get like the same sort of like physical withdrawals like you get from a benzo from that standpoint. But yeah, other than that, not that I'm aware of. Instead of a sleep sound machine, you should release a product called Farm Sound Machine and sell it to PA students to cure insomnia. You guys are already paying for school. You can listen to my stuff all night long if you wanted to, and that could certainly cure your insomnia right there. I need like an ASMR farm channel, or just kind of read through the PDR or something like that and just get real close up on the mic. I'm not going to do that here because that would probably wig some of you guys out, and I don't want to do that. Probably be bad on my reviews as well. Anyway, love all your questions. I really appreciate that. Love interactions. So anyway, so the sleep aids here, we're going to see with the benzo-like drugs, either using benzos themselves or benzo-like drugs, as we'll see here in just a little bit. You don't want to use in certain cases because of some of the kind of ancillary problems you can run into. So for instance, if you're having trouble sleeping while pregnant, you don't want to use benzos because those are teratogenic, right? If you have sleep apnea and you already have sort of this kind of chronic depressed response to CO2 because of body habitus or whatever the reason why you have the sleep apnea, this can depress that further. So certainly, cases of people having died with sleep apnea while taking a benzo for sleep, sure, I'm sure they're out there. If they have a history of substance abuse, again, these are addictive substances, so I would avoid that for those. And then definitely avoid other CNS depressants, especially alcohol, and this is probably the most common one you're going to see used in combo. They're just too synergistic. It's very much kind of throwing the dice to see how they're going to respond to it. So I would definitely not recommend that. Anyway, so looking at the agonists here, you're going to see that the longer half-life drugs you have, certainly it might keep them asleep throughout the night more consistently, but they're also going to be more likely to have that daytime grogginess and daytime maybe inability to get up, get moving, wake up to their alarm, get driving to work, whatever the case may be. They will also develop tolerance over time, right? So I'm not sure if there's like a whole lot of evidence showing there's tolerance like stuff like melatonin, but certainly with this, you're going to develop some tolerance. So they may need to go up on their dose as time goes on. And you do get rebound insomnia, okay? And again, all the benzos we've talked about before, so like your Ativans and Midazolams and diazepams and chlordiazepoxide and all those drugs still fit the bill here, right? So you should still be able to recognize a benzo if I were to ask about one on a test question for sure. The ones here that are kind of new to us are the non-benzodiazepines. I call them non-benzos basically because they kind of still do the same thing, but they don't fit into the benzodiazepine sort of category. And so these are specifically GABA A agonists, right? So just like the benzos are. And this includes zolpidem, zaleplon, and esopiclone. You may see these referred to as the Z drugs, and it kind of makes sense. The Z drugs, going to sleep, But this is where you get the Ambien, Sonata, and Lunesta drugs here. And so kind of looking at how they kind of comparing the different kinetics of the drugs, you can get an idea of how the drugs might be useful for certain situations versus others, right? So for instance, if I had something to where someone had a hard time staying asleep, then maybe using something like astaxanthin, which is a benzo, would be better. But of course, your risk for having daytime grogginess is pretty high with it lasting that long. Yeah, so Cassette, thank you. That does lead me to the walrus. So some people will talk about the Ambien walrus. I've heard a few other terms for it. But yeah, so those drugs are particularly bad about causing a lot of like sleepwalking and things like that. So I at least had one acquaintance who had a lot of trouble sleeping, they had chronic pain, and they were prescribed Ambien, and all of a sudden, like a couple of days later, they had like an Amazon box show up at their door, and it was like some kind of like Mountain Dew paraphernalia. Like she loved Mountain Dew, and I guess she like went onto Amazon in the middle of the night and ordered all this like Mountain Dew like shirts and hats and all kinds of stuff, and she had no recollection of it whatsoever. So yeah, those are certainly things you can see. Again, they can have weight gain as a side effect because of the sleep eating that people can do. So yeah, you got to just be careful there, and certainly you can see plenty of other stories online for sure. Someone said, would be preferred to start someone off an RX of trazodone before starting a benzo? That's a good question. I think that might be really dependent on the user. I think or the the patient. I would say if they had like concomitant antidepressant medications, I probably wouldn't jump to trazodone right away. If it was someone who had a history of substance abuse, yeah, certainly I would try trazodone in that sort of situation there. So you want to look at the contraindications. You want to look at, what may lead you to pick one versus the other. Certainly, overall effectiveness, I think I'd probably say benzo is probably a little bit more effective, but that's just because of the mechanism. But yeah, there's certainly a lot of downsides to using them as well. So my goal is not always to jump to the benzos because again, can't have their problems as we're seeing here. And again, if they have a problem just getting to sleep, then using something more short acting might be a better option there. So something with a short half-life like Zaleplon might be really good for that as an example. Some of these you may even find like in a controlled release preparation. So that way, even if they have a short half-life, then they can have a slow release. That way you get, kind of more consistent levels throughout the night. Again, I'm not going to ask you which ones of these are long versus short acting necessarily. I just more want you to have an idea of like, okay, why would I pick a long acting one versus why would I pick a short acting one? What's the downsides of using a long acting one versus a short acting one? Those are kind of the things I'd like you to be able to identify. But these are the main benzos that you're going to be seeing used for sleep purposes. So at least be able to recognize these as benzodiazepines. And again, we talked about our Z drugs being kind of the non-benzo benzos in terms of their being able to recognize their actions and side effects and all that sort of thing. Okay. A couple other things we could use includes the drugs modafinil and armodafinil. These also fit into the C5 category here. And these are actually interesting because they're more used for daytime sleepiness. So if you had a patient who I've seen this used for narcolepsy, but more often for shift work disorder. So if you work at nighttime and you work typically like the 7P to 7A shift, for instance, and you get home, your body says, okay, well, I'm tired, I'm going to go ahead and go to sleep, but your circadian rhythm is just like, it's daytime, the sun's out, we got to party, right? So that can be a big problem, especially if you happen to be working maybe a less ideal shift. I tend to see, especially like in ERs, like PAs tend to get sort of like the 3 to 11 shift, but sometimes if you work overnight you can run into this. I thought I said C4 on that. Yeah, this is in the C4 category. Sorry if I misread my Roman numerals there. But yeah, so modafinil or modafinil are both on the C4 category. But anyway, so with this, you're going to be able to use it for that. Basically, it's trying to kind of reset their circadian rhythm to a degree to help them be able to sleep during the daytime and then get up and go work at nighttime and not cause too much excessive sleepiness during those times there. Again, it can work for narcolepsy as well. So there's some interesting videos out there of people kind of before and after modafinil to see how it kind of works for their narcolepsy. We don't know how it works. We just kind of know that it does. So it's kind of interesting. And in terms of side effects here, it's mostly going to be things like insomnia, anxiety, nervousness. So kind of this kind of increased sort of energy sort of aspect to it. So that's one thing you'll see with that. Anyway, so that's it for the sleep drugs. That's it for the surgery section. I know it's kind of a oddball mix of topics, but I figured I'd just cover all the sedation stuff and the anesthetics. Yeah, so do you guys have any questions or anything that I can answer for you before I let you go? So that's the end of the test material. So for test 3, it'll go from endocrine, nephro, urology, and then surgery. So those are the 4 sections on the test. We'll have our review tomorrow. for which I will be live. So I believe some of my friends here in the chat are going to help out with the sign up sheet on your Google Doc drive, whatever. And so if you guys can figure that out, again, don't all sign up at once. I don't want anyone to feel too disappointed, but I'll just be in person, but I'll still do the YouTube video. So you'll still have the same link there. Actually, no, I'll do it as a Zoom actually, because I want to be able to have other people interact if they want to, but I'll still be recording and I'll still post it up, and we'll do the same thing as usual. So it'll be like a typical review. I'll just be in person for the people that are in front of me. So yeah, and that should be it. So any questions? Someone says, can you give an example of a situation where you'd want to use a short-acting sleep aid versus long-acting? Yeah, so if the person says like, oh man, like I kind of sit there and when it's time to go to bed, I just like sit there and I close my eyes and I just sit there for a couple hours, and then once I go to sleep though, I'm totally fine. I can stay asleep. That might be a good person for like a short-acting sleep aid, so something like Lunes or that Sonata might be a good option there. Versus if they have a more of a difficult time staying asleep throughout the night, that may be a better case for using a long-acting sleep aid in those cases there. Yeah. Jackson said, hopefully you'll be able to come to BlimFlex in person. Well, yeah, I hope whoever wants to come can come. I'll be sad if there are people who are unable to secure a spot. But maybe, I don't know. I can't fight you if you show up. I don't know to I'm not gonna like kick anyone out, I guess, but I just want everyone to be safe and socially distant and all that. I guess I'm supposed to kick you out more than 24, but maybe I'll forget to count. I don't know. We'll see. But yeah, what other questions do we have? Yeah, thank you all for joining me. I appreciate it. Oh, I'm glad you're excited for the BlimFlex. Don't get your hopes up too much. It's going to be just as boring as my normal lectures are, so I don't know that me being in person is going to help it with that necessarily. Maybe it'll be like seeing like a Z-list celebrity or something like that. This will be like, oh, this person I see online all the time. I can finally see in person for once. Yep, thank you. All right, so I don't see any other questions, so I will hopefully you guys will hold them till tomorrow, and then I will see you all later. So have a great day.